Hello friends, this is a case of rectocele and we are performing the sacrocolpopexy to repair that and to get a better vision of the posterior cul-de-sac. First step is that we should fix the uterus so that uterus should not come in your way of dissection, and once we will try to find out our dissection up to the levator ani, then uterus will not hang over your instrument. So you can take a bite with the vicryl or silk from the anterior abdominal wall and pass it through the broad ligament, and then again pierce to the other side of the broad ligament, and then again you can pierce to the anterior abdominal wall. Care should be taken that it should be not just above the pubic symphysis bone. It should be approximately 5 centimeter above that, so that it should not prick the bladder. And we can see here uterus is lifted up and now you have a good vision of the pelvis, and then it will be easy for you to dissection of the pelvis. So we can see here this is the sigmoid colon. Here in front you can see the right common iliac vessel is pulsating, and these are the epiploics of the sigmoid, and here is the aorta and there is the sacral promontory. Ureter is crossing the external iliac. You can see the peristalsis of ureter which is visible. So our dissection will start from the sacral promontory, and that will the peritoneal dissection, and that has to go up to the start of the uterosacral ligament. So peritoneal tunnel is required to form, and we should remain on the right side because right anterior longitudinal ligament has to be used for fixing the mesh. So we should not go to the midline just to prevent injury of the median sacral vessel and to prevent injury of the hypogastric nerve, because before cutting the peritoneum you should keep it stretched anteriorly, and then tunnel of the peritoneum should be formed. Directly hook should not touch the sacral promontory, and always we should remain hook, look and cook, and direction of the hook should be, while hooking, should be always towards the anterior abdominal wall, because laterally you have the common iliac and external iliac. So once you will make a small nick in the peritoneum, that CO2 will help you, because gas will enter into the preperitoneal pocket, and then you can still carry out the blunt dissection. Only peritoneum need to be cut sharp. So this step can be done by the harmonic also, and you can use the monopolar scissors as well. But here we are using only the hook, and slowly this peritoneum right to the rectum will be carried out, taking care that it should not touch the anterior longitudinal ligament directly, and always the blunt dissection should be performed. We should also avoid touching the rectum. Here ovary and tube was also coming in the vision. So one more bite of the suture was taken through the anterior abdominal wall, and it is pricking the ovarian ligament, and then ovary and tube also will remain hanged up. That will give you again a good vision, and your peritoneal dissection over the posterior leaf of the broad ligament will not be affected, and you have to be remain medial to the uterosacral ligament. So once it is lifted, you can see entire posterior leaf of the broad ligament, and then you will not go near the ureter, you will not go near the internal iliac, and you will not go towards the rectum also. So good vision is important here, and always remain white is right and remain towards the rectum, but fat belongs to rectum, so don't touch the rectum. There is a gauze piece which we have used to just prevent the oozing. If you have any oozing, you can just press it over the sacral promontory, because it is not wise to use a lot of electrosurgery, especially monopolar at the level of sacral promontory. That will damage the hypogastric nerve plexus, and also important that this oozing better is controlled by the pressure. So you can just push it and keep the pressure over the oozings. So now the further dissection will be carried out, and then anterior mobilization also has to be done. Now at this stage we can make a tunnel so that we can pass the mesh through this tunnel, and the purpose is that once this mesh will go anterior to the rectum, and then we will fix it over the levator and eye muscle. So it should must be medial to the uterosacral ligament. In any chance you should not go lateral to uterosacral, and another, it should be anterior to the rectum, and this tunnel will be formed. However, you may split it, but splitting will do the little more suturing is required. So now the cul-de-sac peritoneum will be separated, and anterior mobilization of the rectum will be performed, so that you can reach up to the levator and eye muscle. So peritoneum is lifted up, assistant grasper, here this is the laparoscopic grasper, and assistant will give cranial traction over the rectum, so that it will not come in your way and it will be fully pulled. It is better to hold the epiploic or tinea coli during giving cranial traction. So separation of the peritoneum in between the two uterosacral ligament will be carried out, and after that rectovaginal fascia will be opened. And always remember here also that fat belongs to rectum. So always we should be anterior to the fat, and here the fascia is two layered, so it will be easy, and always we should progress to the white color plane. So it should be a combination of blunt dissection. Together with the peritoneum, you can use a sharp electrosurgical dissection. Many a time assistant can put the finger into the anus and he can give you some idea about the divator muscle so that you can reach to the easily at that level, and your plane also will not be deviated, it will be going to the correct plane. So, we can see this finger movement of the assistant is visible and he is guiding you to find out the levator ani muscle and knowing you the what are the boundary of the rectum and the anus. That will help a lot to get some anatomical consideration, because in robotic we don't have any tactile feedback, so you cannot feel the muscle. So that's why visual interpretation is required, and that will be helpful. So we can see this is the finger and which is giving you the pressure over the muscle, and then you can find out the boundaries of that muscle. This is the right side, and then left. Dissection is almost complete. This sponge has just soaked the some of the oozing which was there in the peritoneal flap. Now we will take one needle holder and make a blunt peritoneal window on the distal part, just to facilitate the entry of the mesh. So this is done, and now that much window is enough to pass the mesh. So now the main part of the sacrocolpopexy will start, and then we will take a ethibond suture, that should be non-absorbable polyester, and there is a polypropylene mesh. That mesh will be 15 into 3 centimeter mesh. This mesh will come through this tunnel one end of the mesh we will fix to the levator ani muscle, another end will be fixed to the anterior longitudinal ligament on the right side over the sacral promontory, and after that these all peritoneal defect will be closed. So, this we can see that this one end of the mesh is pushed over the levator ani muscle, and then it will be sutured with a deep bite with the muscle. It will go through the one of the hole of the mesh, take a bite on the muscle and then come it out with the another hole of the mesh, so that you can suture. And here it is important that it should be a non-absorbable suture. So, 2,0 Eth bond is used. Eth bond XL is polyester suture, and it is multifilament and it does not have memory. So, tying the intracorporeal knot is also easy. We can see the other end of the mesh is getting internalized through this window, and it is pulled in this distal end is covering anterior to the rectum, and then will be fixed with the levator ani muscle. So, this is ethibond suture with the curved needle and going through the net of the mesh, taking a bite on the levator and coming out with the mesh. This is deep pelvis. So, in the deep pelvis taking a bite is little difficult, but thanks to the Da Vinci that even in the narrow pelvis it can work better because you have a depth perception, 3D vision, and then motion scaling. At that point in the deep pelvis suturing, you can get fine or ultra fine motion scaling, so that your crude movement will be translated into a fine movement, and that will also be easy to perform the procedure. In the video what we are seeing here, that is a 2D video, but surgeon what we are seeing is 3D. So, there is a big difference between the two image. What you are seeing on here on your screen is only 2D. So, that has less your information compared to what we are seeing in our console. So, this is fixing with the apex of the levator ani muscle. So, slowly this part is sutured. Now, another bite is taken. So these are intracorporeal surgeons knot. This is mega needle holder with the scissors. So needle holder base has a scissor, so needle holder will cut the suture also. You can take a bite over the uterosacral ligament also. So this is done. This is the anterior wall of the seromuscular part of the rectum. That also is sutured with the mesh. This is a mega pore mesh. So passing the suture also is easy. So this is done. After that, needle will be taken safely. An assistant will bring a laparoscopic needle holder to remove that needle out. Now this part of the mesh will be fixed with the anterior longitudinal ligament on the right side. You can use tacker also to fix over the sacral promontory, that is titanium tacker, but here we will use suture only to fix this. So this is the new suture, and this mesh will be fixed with the sacral promontory. You can pass the needle through the net of the mesh, and then after lifting you can take bite, because after keeping the mesh over the sacral promontory, sometime vision will be obscured. A bite is taken so that the mesh may not, suture may not come out. You have to be careful with the mega needle holder, that if accidentally you will catch the suture by the base of the needle, it cut the suture. If you will catch the suture by the base of the needle holder, it will cut the suture, which has occurred here. The suture was cut, but still the length is sufficient to tie one knot. So, always with the mega needle holder, with the scissors, we should hold the suture by the tip of the needle holder, not by the base, otherwise it will get cut. So, now excess of the mesh will cut out, and then one more fixation will be performed. With the, this is, you can see pearly white color anterior longitudinal ligament is visible, and first the bite is taken over the anterior longitudinal ligament, and then it will be passed through the net of the mesh, and this is the second bite taken for double security. Epiploics of the rectum should be remain away. And it is done. After that, we have to close the entire peritoneum defect, so that any portion of the mesh should not be in the abdominal cavity, it should not be visible, and healthy peritoneum is the best known adhesive barrier. So, once the peritoneum will cover the entire mesh, adhesion will not happen. These all needle better to tell the assistant to pull out, because keeping it long time inside the abdomen is not safe. So, it can do the accidental migration and can go to the wrong place. So, now this is a simple vicryl, and this vehicle is doing the closure of the peritoneum. That is very easy, just continuous suture you can use. So, this is a simple vicryl which will close the peritoneum of the cul-de-sac and this tunnel of the mesh. So, this is the starter knot. You may use Dundee jamming knot, but here it was started with the surgeon's knot. And then this is the continuous suturing to close the peritoneum. Peritoneum always tolerate continuous suturing better. Interrupted is not good for that because it will cut through. And we should be careful that after taking 2-3 bite only we should pull the suture. If every bite you will try to tight it, it will cut through. So we can see slowly this defect is getting closed with the continuous suturing, and like a purse string, once you will pull it, it will close, and after 2-3 bite you can do Aberdeen termination, so that loop within loop and take the needle out, then it will not go back, and then further continuous suturing can be performed. So this is Aberdeen termination. You have to take loop within loop and then take the needle out through the loop, which we are always using in the open surgery also to close the peritoneum. So this is locked. After that, further suture you can carry it out to this proximal part of the peritoneal opening. Here again one starter knot is required. You may use barb sutures, but for peritoneum Vicryl is enough. We can see entire mesh has gone retroperitoneal, and any part of the mesh is not inside the abdominal cavity. So entire mesh is covered with the peritoneum. This is the final termination. And it is over. After that, assistant will again bring a needle holder, laparoscopic needle holder, and all these suture and needle he will pull it out. This sponge also will be taken out. Now there will be one final inspection, just to make it sure that there should not be any bleeding, and this stay suture which was taken, that will be also removed. The prick point of those needle will be checked, and after pulling the suture out, if you have little any oozing, you can touch it with the bipolar and that will stop. So it's over. So thank you very much for watching this video, and this was a case of robotic sacrocolpopexy. Thank you very much. Have a nice day.